Dr. Henri Welch from the project will present lessons learned in diagnosing extra-pulmonary TB. So the floor is Henri's.
Thank you for the opportunity to present on extra-pulmonary tuberculosis in children. My name is Dr. Henri Welch, and I am a pediatrician working in Port Moresby, Papua-New Guinea, or PNG. Next slide. TB is a huge problem in PNG. As far as absolute numbers, it is not as big as other countries. However, as far as TB incidence, it has the 7th highest rate globally. More concerning is that 26% of the total reported TB cases occur in children. For a country of around 8 to 9 million, there is only one primary referral hospital, which is located in the nation's capital, Port Moresby. Here at Port Moresby General Hospital, we diagnose around 1,000 children a year and admit around 500 children a year. Nationwide, there's a 10% in-hospital mortality if you're diagnosed with TB. HIV co-infection is around 8% of children with TB. However, an even bigger problem is malnutrition, which is present in 40% of children that are diagnosed with TB. Next slide. The diagnosis of TB in children is pretty similar here to other countries. It is done through careful history, examination, skin testing when possible, although we haven't had the tuberculosis skin test available for many years, bacteriological confirmation, X-ray and other labs, as well as HIV testing. Just note on bacteriological confirmation. Children with presumptive drug-sensitive TB doesn't really change our management too much, but we do try hard for an expert when drug-resistant TB is suspected, for example, a contact who has MDR, or if they're failing first-line drugs. Of our 1,000 children that are diagnosed with TB each year, we confirm around 20 to 25% of them as having bacteriologically confirmed TB by gene expert. Next slide. Extrapulmonary TB is common in children, and often children present with both extrapulmonary and pulmonary features. The real prevalence is difficult to know as far as extrapulmonary TB, because if they have any pulmonary involvement, it is recorded as pulmonary TB. Peripheral lymph node is the most common form of extrapulmonary TB, and this was seen in PNG, which is similar to other places, including meningitis, abdominal TB, pleural effusion, and spinal TB. The first case is an 8-year-old boy named AK. Next slide. He's an 8-year-old boy, you can see in the wheelchair, who has had multiple visits to the clinics over the last few months. He's had 3 weeks of fever and cough, poor weight gain, although this is reported and not documented, as he doesn't have a clinical book. He's clinically well, although tired. As far as contact history, his mom has pulmonary TB and has a gene expert with MTB detected, as well as an AFB smear, which is 3+, and she's admitted to the adult ward. He also has a younger sibling who's 5 years old who had a gastric aspirate done for suspected pulmonary TB, and he had MTB detected as well. Next slide. On exam, he's otherwise well, but he's thin. His vitals are stable. His weight's less than 3 standard deviations for age. He's got no lymph nodes. His respiratory exam is abnormal. He has decreased chest expansion on the right, decreased breath sounds, and it is dull to percuss. Next slide. We were fortunate enough to have a chest x-ray done in the system that was performed 3 months ago for reasons unknown. The repeat chest x-ray now shows a pleural effusion on the right. Next slide. AK was admitted to the ward. He had baseline tests, HIV tests, diagnostic pleural tap. He wasn't coughing, and we don't have the ability to perform induced sputum here. So we ended up doing a gastric aspirate for a gene expert, although maybe we didn't need to do that. The results all came back negative, including his gene expert AFB smear. Culture isn't available here. Pleural food was unremarkable. Next slide. So what do? Well, a gene expert can never be used to rule out TB in children, and now is just a point to make on the quality of the specimen. Ideally, we would have the bed space to perform early morning gastric aspirates, but we just don't have it. What frequently happens is they're asked to come in on another day, so that means they have to wake up, get on a bus, and then wait outside the clinic to perform a gastric aspirate. This isn't going to give a very quality specimen, which is why we can't rely on gene expert to rule out TB in kids. In this case of AK, he had a 5-year-old brother who was already unconfirmed TB. His chest x-ray looked worse than the patient, and so this was TB. He was started on treatment, he completed it, and now he's well. This is a case of lymph node swelling. Next slide. Lymph node TB is common in children. It's usually in the anterior cervical region. They're usually painless, asymmetrical, often multiple discrete and matted lymph nodes that are usually large and persistent for more than a month. and usually they're not responsive to other treatment like antibiotics. Sinus and discharge may develop, and they're usually between children between 2 and 10 years of age. You can see in the patient in the picture, he's got massive cervical and axillary lymph nodes with sinus tracts already draining. In a TB hybridating setting, we would just treat this for TB. One algorithm that was found to be highly sensitive and specific was in South Africa, where they found that persistent adenopathy, not responsive to antibiotics, was highly sensitive and specific for TB. Next slide. So in this case, the cervical lymph nodes were there for at least 2 months. The mother was treated for pulmonary TB last year, and this is a high burden TB setting. What happened to him was that he lives 4 hours away and referred to the capital in Port Moresby. This can be inconvenient, time-consuming, and expensive for the patient. Is it really necessary? Often we're worried about losing the patient and the time it takes to establish a diagnosis. If you don't have a gene expert testing or a chest x-ray at your facility, what do? In this case, it was obviously TB, and you didn't need to be referred to the capital. You can try and treat with antibiotics if it doesn't go away, but otherwise you would treat him for TB. Next case. This last case is a headache in a 13-year-old boy. Next slide. The boy in the green shirt is 13 years old, and he was previously healthy. He presented with 10 days of fever, headache, and being unwell, and he had a seizure before coming to the hospital and then again at the hospital. He had no known TB contacts that we were able to identify. On exam, he is unconscious. A pupillary exam was done that revealed papillary edema, so a lumbar puncture was not performed. His lab work was mostly normal, and his chest x-ray showed patchy opacities, but was otherwise okay. He was started on ceftriaxone, but there was no change after 2 to 3 days. Next slide. We were fortunate enough to get a CT eventually, although frequently this is difficult to get in many places. As you can see, there's a huge ring-enhancing lesion in the left hemisphere. A gastric aspirate was done, which actually found to have MTB detected on Gene Expert. He was treated with high-dose steroids and TB treatment. The diagnosis of central nervous system TB is challenging. It's difficult to differentiate TB meningitis from other causes of meningitis. For example, it could be viral encephalitis or bacterial encephalitis. Patients often present very sick, and obtaining cerebrospinal fluid or other bacteriological specimens can be difficult. Also, a negative test doesn't actually rule out CNS TB. Many of us are faced with a sick kid presenting with severe CNS disease. In high-burden TB settings, how long do you really want to wait to start TB treatment when it is hard to rule out? As a rule of thumb, it's a clinical decision, but if children fail to improve on 48 to 72 hours on TB treatment, on standard bacterial ceftriaxone treatment, they're often treated for TB meningitis. While this no doubt overestimates the burden of TB meningitis in PNG, it probably also saves a lot of lives. Next slide. This last slide is just to remember that you can make a diagnosis of TB with confidence in the majority of children using careful clinical assessment. It is difficult to confirm the diagnosis of TB, but it's not so difficult to make a clinical diagnosis of TB in child. Thank you.